I'm neither pro nor against MR, at the contrary, but I must apologize, I'm rather a photon guy than a proton guy. I use the imaging to treat patients. I'm rather an interventionist, so I only use the tools I know how to utilize. The challenge we face is to get through occluded veins occluded sometimes for many, many years, decades sometimes, and we use a specific protocol with dorsopedal access. We puncture vein on the top of the foot, just before the ankle. We have a delayed acquisition to adapt to the slow vein blood flow, with tourniquets to trap the contrast into lower lines. We do a second acquisition 1 minute after, just in case the delay was not appropriate for that specific patient. And we do imaging from knee to thorax. If we do not want to use specific pedal access, for instance, for chest patients, we convert to an antibrachial venous access, and we use as much as possible of a high contrast agent. The specific thing we look for are the things that are going for us to say to the patient if we have good chances of success or not. And these are the synechiae. Synechiae are the remnants of thrombus, of chronic thrombus. They are like walls within the vein. They are predictors of bad result, or rather they indicate that we have to perform dilatation, balloon dilatation into them. For instance, this is synechiae. These are these walls within the vein. We see them still more clearly here. And after that, we get a volume we can reconstruct to get bone landmarks, which are especially useful during recanalization. Of course, you can input them into your fluoroscopic image during intervention. These images have been given to me by Antoine Bouvier from Angers. I am an old man, and I'm not very familiar with these tools, but they definitely are very useful. If I have someone to put it on my screen for me, I'm very, very glad. And this is a result after recanalization with the stent inside. Of course, you have a superimposition of the fluoroscopic image with recanalized vein, with patent vein, superimposed with the CT image with occluded vein. In acute obstruction, it's somewhat more simple. We have just to look for the extent of the thrombus and look for a May-Thurner syndrome. This, for instance, is an example of a young lady that we have treated 2 weeks ago. We just have to see that the vein is filled with thrombus. Here the femoral vein, and we see also that the iliac vein is not visible. It's here, and it's chronically occluded, or it is a May-Thurner syndrome. This is why deep venous thrombosis occur most of the time on the left side, especially in women. Of course, you can do a kind of fusion yourself with drawing a tract on your workstation, and this gives you approximately the route for getting your guide within the occluded vein on fluoroscopic guidance. So I use CT because I have good access to it and I'm familiar with it. Same problem for renal tolerance and allergy radiation exposure. It's a one-time imaging. It's not repeated imaging for these patients after they are followed up with duplex Doppler. And the spatial resolution is especially useful for us to see these synechias. I have not found much literature on this, and what I've told you is based on my own experience and the experiences of my more experienced colleagues from Grenoble and Nantes. Thank you for your attention.